really impressed by this project too. It's at NIATx, you know, we're at the University of Wisconsin. We get exposed to a lot of things that are happening nationally. And I'm having a lot of people come up to me now and say, hey, there's this really cool thing we should be doing. It's called integration. You know, could we you know, do a, you know, will you come speak at our conference, or will you do this and that? And I'm like, well, some folks have been doing this for 12 months already, you know, and that's you guys. So I think you're definitely on the leading edge of a trend. So I think, and OSI usually is pretty good about identifying things and getting things out in front. So very impressed. What I would like to do quickly before I just talk a little bit about just sort of some background stuff related to the project and just what's going on around the country and the like is just do some introductions, just so we know who's who. And I think we'll have some folks that will still come in and we'll grab them. But why don't we just start? Name, where you come from.
My name's Manette Mata, and I'm from Epic Counseling Center of Baltimore. We're a facility in Baltimore County. So I'm the clinical coordinator of the Lansdowne office.
Great.
My name's Lindsay Carden. I'm also from Epic Counseling Center. I'm the program development coordinator at the Catonsville location in the administrative office.
Okay. Very close to here.
Jillian DeFranks, Epic Counseling Center. I'm the fiscal coordinator at the Catonsville office.
Okay, great. And then Aileen, who you're going to hear from off and on. Why don't you introduce yourself all this time?
I'm Aileen Warren. I'm with NIATx.
Yeah. We're her start
yeah,
too.
I'm in Indiana.
And then it's done a lot of stuff here.
I'm Julie O'Kahey from University of Maryland, Georgia.
Julie?
I'm Jeffrey Farr, also from University of Maryland, Substance Abuse Counselor.
I'm Beth Jones from the Harford County Health Department.
Mary Claire Britt, Harford County Health Department.
Cheryl Deers, Harford County Health Department.
Okay, awesome. Okay, what I want to talk about in the first half an hour, 45 minutes is just some background kind of stuff. Of just, you know, what's going on with this integration stuff and health reform and stuff like that. And I'm going to try to find my presentation. Oh, here it is. Awesome. I can do this. And will this thing. Wonderful. I told you I like technology, and I'm easily impressed, by the way, too. Yeah. So hey, what I want to start out with is this notion that the world's changing, and I've had this slide for the past 3 or 4 years, and it's sort of, in fact, you know, I'm an academic from the University of Wisconsin, and so I sort of. You know, I like to have these research questions or things that just sort of pique my intellectual curiosity. And it'd be fun to do like a little study of how people have reacted to this slide over the last 4 years. Because 3 or 4 years ago, even 2 years ago, last year even, I put this up, and you know, especially a lot of addiction folks would be looking at me like, "What do you mean the world's going to change? What are you talking about? Everything's just fine." And then over the past year, they're like, you know, no blank, dummy. The world is changing, and we're feeling it. I mean, there's a lot of stuff happening. And really, that's what I want to talk to you about today is just what are some of the changes, or what's causing some of the change going on. And I'm really going to focus a lot on integration and just what's happening with integration. But I think it's interesting to sort of look at what's causing it and sort of how it's playing out in different situations I'm involved with. So, I like history a lot. I admit, like my favorite magazines, like Smithsonian, because I can sort of get in there and read history. And having been, you know, got a master's degree in health administration, you know, they give us a lot of history and, you know, how healthcare has sort of progressed. And if you sort of look at healthcare, there was a whole lot of changes that happened in the mid-1900s as they developed things like hospitals and nursing profession and licensing of physicians. And then things have stayed fairly stable, really, since then. And really most of the changes have been technology related. And then if you look at addiction services, even behavioral health services, you know, the whole field sort of came to be in the 70s and 80s, and then it's sort of stayed pretty consistent since then. And I think what we're seeing right now is probably one of the first, really, I think a lot of people will say really the first major shift is when they went from 28-day programs to the current model. And I think what we're seeing now is the next sort of major shift. And I think the major shift basically is going to be how addiction services become part of the general healthcare field. I mean, and I think really it's sort of funny is the way it's been told to me is addiction services is very much a cottage industry as people were concerned about this and no one else wanted to really deal with it. And now more and more people realize they really should be dealing with it, need to deal with it, and it is creating a whole set of events. Okay, I want to talk about some of the different movements that are really sort of influencing where we are right now. And the first one is going to is that particularly around substance abuse, you know, there's just a huge need out there. Have all of you seen this slide? This has become a pretty common slide. Ryan, you've seen it. And who put this slide together was a gentleman by the name of Tom McClellan. You know, and he was an ONDCP. I always get that I have trouble with that acronym. And that over at the University of Penn. And he, you know, about 5 or 6 years ago, you know, he sort of pointed out a real basic issue that, you know, specialty treatment is taking care of 2.3 million people, and then we have all these other people who need services. And you know, I think for people that work in the field, they're like, yes, we know that. That's the way things have been for a while. I think what we're starting to see that's changing is how people view addiction. And they're really, and I know it's interesting as I talk to people about this, they're like, wow, God, it seems like we're always fighting uphill for funding and this and that. But we really are seeing some changes in perception and some changes in how people view how addiction's being perceived. This is a study from 2 or 3 years ago that was taken about the time that reform was being discussed. And what they wanted to do is see see what kind of support there was for addiction services within reform. And really the results, you know, it was done by a university firm, and they did a nice randomized sample, and then they found that 77% of Americans felt that addiction services should be included in reform, which I think for a lot of people that was a bit surprising. You know, I think a lot of people are like, not many people even know about it or worry about it. And they, there was some differences between Democrats and Republicans, as to be expected. But even with Republicans, nearly 3/4. So it really shows that, indeed, there's a perception of a need. And you see little things like Wisconsin, the fine state I hail from. The leader of binge drinking, the leader of drinking of all that's bad. And in fact, the biggest lobby there is Miller Brewing. It was the last state to go from an 18 drinking age to 21. And just over the past year, they've really started pushing very hard on DUI kind of things. And so you sort of, especially multiple offenders, that's really, the public's getting very upset about that. And the cool thing now is whenever there's a traffic accident, they will say whether or not alcohol or drugs were involved. And before, when I first moved there, you'd never hear that at all. It was just sort of like, oh, there was this bad accident, what a shame, and it was pretty clear at times that there was other things happening. So you're really starting to see where people are appreciating that it's an issue. Another thing that came out of that same survey that was very encouraging is people realizing that addiction as a disease is not an acute event. It's an ongoing issue. Where I'm starting to see, a lot of just public interest around addiction issues, and particularly as it relates to primary care, is around the use of the non-medical use of prescription opiates. I know you guys are having a little of that here. I just know from some of the site visits. A project we have now in Ohio, and really Ohio has been interesting. It's sort of on the cutting edge of the use of opiates. And what they've done there that's really caused them to have a lot of attention is they started 5 years ago. I'm going to show this to her. They started 5 years ago where any time a person died of an overdose, they would make a record of that and send it to the CDC. You know, you guys starting to do that here at all? And then so they started doing that, and they just started doing it just to collect the data. And then 2 years ago, a milestone was hit where more people died because of overdoses than motor vehicle accidents. You know, so they had a statistic called, you know, unintentional deaths. And basically overdoses became the leading cause of unintentional deaths. So in Ohio, that became a big issue, of course, because that was a statistic that really grabbed them. And so what's happening now is they're doing a lot of work there, and it's just really interesting. They have a Republican administration there, and they had a Democrat before a couple of years ago, and both have worked very hard on this issue. And where a lot of work's happening right now is in prevention. You know, they're really looking at, they have some pill mills there and things like that. And then also we're just starting a project there on the demand side where we're going to start looking at buprenorphine, which is something that's you guys know well here in Baltimore. And then also just ways to improve treatment there. So, and with those kind of projects, we're seeing more and more primary care getting sort of interested in these kinds of issues. The other let me see, does this thing work? Ah, look at that. Okay, the other thing is around budget cuts. You guys are seeing those in Maryland here, right? And so what's happening with the integration issue around budget cuts, Ryan and I were talking about this a little bit earlier, is what are people doing to try to cut costs as it relates to integration?
Increase quality.
You're trying to increase quality. Yep.
Looking more at primary care.
Yep. You know, looking at can primary care do more?
And prevention.
Prevention. Yep. Yep. Exactly. Combination of mental health and addiction services. Yep. You know, and so those are the kind of things that are happening, and it's really interesting. This is another conversation Ryan and I were having. Is what's been interesting is looking at what the cause of the integration. You know, in some states I work in, you know, they're like, well, let me see at the state level, you know, you have addiction department, you have a mental health department. Those are two different departments. If they're doing sort of the same thing, you know, we can combine them and reduce them, right? And so you sort of like throw them together, and there's a lot of fallout from that. And then you have other instances that are better, but not always, you know, as clean. I mean, not always completely clean is a way to say it. Is we're saying, well, really, if you look at co-occurring disorders and you look at providing co-occurring care, you know, that really is going to help outcomes. And so, you know, when you see those situations, things tend to be designed a lot better. And so, but there is a lot of, you know, can we bring things together? And I think there's a cost-cutting dimension to it. There's as I'll talk to you about a little bit here. There's a good evidence base to it. I mean, if you look at, you know, the integration studies, there's just a lot of good evidence supporting those kind of efforts. Another thing we're starting to see a lot of is use of peer specialists. Are you guys doing much of that here? You know, how's that working for you?
Well, we hired two recently, but because we got the money to hire them, we had to hire them, and they had not been, well, they just recently got trained.
Yeah.
So at the beginning, it was kind of like, we don't know what to do with them. And then they, was that 2 weeks ago, got their training? So it seems to be going good now.
You better? Okay,
Yeah.
Good. Anyone else using peer specialists at all? Yeah, and that's another one where it's funny. You have some folks that are like, you know, hey, this is the right thing to do. There's you know, we're seeing some good results here. And then you got others that are like, well, this is a way to cut costs. You know, these peer specialists don't cost as much as counselors and the like. I think what I'm hoping comes out of that is just good evidence-based models. For instance, where the best model I've seen yet is in Kentucky. You know, they're using peer specialists in their women's programs their women's residential programs. In their women residential programs. And they started, 4 years ago, they took me to the pilot. And in fact, it's really interesting. Usually I do site visits, and the people afterwards are like, Todd, give us some feedback, what do you think? And usually you can say, well, yeah, there's this, there's that. And I go into this site visit, and it was a military model. I kid you not, it was a military model. And at one point, someone had done something wrong, and so this woman, I guess, is like one of the counselors there, shouted, everyone to attention. And people were like in beds and stuff, and they all like jumped to attention. I'm like, oh, this isn't good. So three, and they're like, well, what'd you think? I'm like, oh, you guys have a lot of discipline in your in your program. And then I went and visited one of their programs last month, and you can tell they've had a lot of just soul searching and evaluation and just continuous improvement cycles. It was dramatically different. I mean, they really had a step process of how to develop peers, how peers could work with other people in the residential service there, and truthfully, the professional staff was limited. I mean, it really did rely on the peers, and they had a pretty set program of how to train peers and use them. And if any of you are interested in that, I can give you some context there. I was actually, I was a harsh critic of the approach based on what I'd seen, and I was really impressed with where it was.
We actually, here in Maryland, on the alcohol and drug side and the mental health side, we have job descriptions around, because they have more than just peer specialists. There's peer recovery coaches, navigators. They call them a lot of different things. But one of the, I think, exciting things for us is that we are moving towards getting Medicaid reimbursement. Good. For them. So I think
is it just mental health or mental health and addiction?
Well, they're starting to work together on this. So it would be for both. That's my understanding at this point. But there is an effort to do that. And the movement has a lot of peers that are participating in that project.
If you want to be really recovery based, it's good at the very least for post-acute treatment. I mean, and then it's, at least in the residential setting that I witnessed last month, it was really good too. So I think there's some good possibility there, but I don't think it should just be seen as a cost-cutting mechanism. And then the last with the whole budget cuts is justification of value. That's nothing new. It's something that all of healthcare is running into. The other thing that I think is really pushing integration right now is what I call the evidence. And there's really two now, well, let me ask you guys this, is you hear of primary care behavioral health integration, what kind of evidence or reasons for it have you heard? I mean, outside of, I know Aileen and I have been trying to brainwash you guys for the last 6 months or so, but beyond our brainwashing efforts, what kind of stuff do you guys hear about as why to do it? Maybe why not to? I mean, what kind of stuff are you guys hear as you talk to your peers, go to conferences, that kind of stuff?
Well, that there's a trend to call everything behavioral health, and so you can categorize some of these patients together, and some of these disorders do overlap. Yeah. So treat the whole person, don't, dole them out, you go here, 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 and there, and then they end up, this revolving door through all three systems.
Right, so that's great. So there's sort of a sense of, we got one person here, and yet we're trying to treat them in 3 different ways, or always my favorite is you have a case management conference where you say, okay, what kind of coverage do they have? Okay, that looks like an addiction disorder. Although they have 3 different things, and it's just, what's other things people hear? Not much, huh?
Well, sometimes people don't want to treat the substance abuse disorder until the mental health disorder is treated, or the mental health disorder until the substance abuse disorder is stabilized. And also, when we talk about integration, I think integration with physical health as well. And so sometimes those words get confused. Right. But as you said, treating the whole person at the same time, because it really does become that chicken or egg. And treating it at the same time, congruently, is, I think, the best chance, if the research supports, is the best chance for success for the person.
Right, right, and that's well said. Well said. Any other things that you hear, or just personal opinions, critiques? Now's your chance to speak. Speak out. Just kidding, just kidding. So the evidence, actually the evidence, when you look at integration, the evidence for mental health, primary care integration is very, and I'm talking as a researcher here, is very, very strong. There's something called the collaborative care model that was developed at the University of Washington, and they developed that back in the late 80s, and they've been, and actually the late 90s, and they've been researching it heavily for the last decade, and they show that when people are treated with their co-occurring issues, that healthcare costs go down and outcomes go up. With addiction integration, the research isn't as strong. I mean, and when I say it's not as strong, it's not as strong. It's not that it hasn't been proven; it just hasn't been as much. There's something called the PRISM project that really showed a lot of the same outcomes as a collaborative care. That indeed that the patients do better. That overall costs go down, and that's healthcare cost, and that doesn't consider any kind of judicial cost. So there's just some good research evidence around integration.
To me, personally, I think a piece of evidence is really research that has been done. Some of it's been from Oregon, I think, that the death rate for people with a co-occurring substance use and mental disorder die at the age of 45, whereas someone with serious mental illness, their average age is 56.
Yeah.
So somebody with a co-occurring disorder, and then you're not also adding in a traumatic brain injury and other comorbidities with that. So, I think these people are dying young.
Right.
And I think that alone says we need to do something here.
That's some stunning research numbers, isn't it? Is the average age of death of people that have those disorders compared to the general population. So the need's certainly there.
Yeah. I'd also like to point out that there's a big difference between collaborative care and integrated care.
Yeah.
And that I think people need to understand that difference so that everybody's clear as to what they're actually, doing.
So say a little more about that.
Well, when we talk about collaborative care, we're talking about how behavioral health works with primary care. When we're talking about integrated care, we're talking about how, or it could be vice versa, or it could be how primary care works with behavioral health. Or when you're talking about integrated care, you're talking about how behavioral health works within. So you have to remember those two little words, with or within.
That's well said.
So it's how that works within primary care, or how primary care works within behavioral health. So again, I think when you have a good understanding of that, then you can stop and say, wait a minute, is this really integration or is this collaboration?
Yeah, and the evidence is supportive of both. But I think you're right. It gets when you get into integration, it seems to do better. But the collaboration there's a significant step between collaboration and no collaboration. So it's a good distinction. So other types of evidence, and it's interesting. I'm an academic, so I will confess. Yes, I like the research articles, but when I get really impressed is when I talk to people and they say, "Hey, this is cool. This works." And I find really without exception, when people are doing integration, that once they are collaborative care, and I'm going to use integration just because it's easier rather than saying both words. Once they start doing integration, it's hard for them to go back. And we accept this one exception: if you have like a behavioral health specialist in a clinic and they're not being used. You know, and sometimes you have that. But whenever there's some kind of integration, usually what people will say is, God, I don't know how we got by without this before. You know, this is such a help. And really, what's happening typically is you have physicians and their staffs who haven't been trained, you know, for behavioral health issues, don't have the time to address it, nor the expertise to address it. And then when you get into addiction issues, you know, you have the whole drug seeker kind of things that are going on. And so they've been trying to deal with these issues. How they've gotten away with dealing with these issues is to ignore them. But more and more payers are saying you can't ignore it anymore. It's going back to some of those issues I was saying earlier. So they're looking for help. And then when they get it, they're like, yes, this is really helpful. And I think they also have to confess at that point that really these behavioral health issues are impacting the physical health issues. And we really need to be dealing with both to be successful. You know, especially when you're looking at things like diabetes and heart conditions and things like that. So for me, it's, you know, sort of the word of mouth or just the evidence from the streets is really strong. And where I see it the strongest actually is I got a project I'm doing in the VA, and their integration is much stronger there than the private sector because they have these enablers that make it a little easier, like a shared medical record, which, you know, is sort of nice, you know, where you can type in and say, oh, that's what the physician did, or that's what the counselor did. But there they don't, and it's really, even there though, you have different levels. Like I'm working with 2 different groups right now, and one group's doing collaboration, one's doing integration, as you said. And both of them are like, we won't go back, but, you know, I'm talking to the collaboration group saying, you know, there's a little more you could do here, you know. And they're like, really? Yeah, you should try it, you know, you like it, you know. So, so, you know, so when people get there, now I realize there's challenges in getting there with reimbursement and just, you know, existing patterns, and we're going to talk about those here as we talk about our projects, but people, once they get into it, they typically like it. Okay. The other movement that I think is just, in my opinion, is undeniable right now, but I'd be really curious to hear what you folks think. And I've made up a new word here. I'm surprised that, it's funny, I've used this enough, my spell check doesn't do the squiggly line under it anymore, but the medicalization, don't ask me to say that again, of addiction treatment. The medicalization of addiction treatment. What do you think I mean, Mary Ann? You're smiling about it, but I mean that.
Well, for a long time, we've used a disease model for addiction because it is said to follow a progression. It has a diagnosis, and what we found with certain specific diagnoses within addiction, medication-assisted treatment is very helpful. So, and we need doctors to prescribe those medications, buprenorphine, methadone. There's several that would work with that. So when you use the disease model for treatment, made up word like medicalization would work. But also, when you talk about integration with physical, somatic, or a doctor's office, that would be another way of looking at that as well. So
yeah,
that makes sense to me. It's a funny word, but
you're not going to use it yourself. I don't blame you. But no, what the interesting thing for me is my background is from hospital and clinics, and so as people have been talking about the trends here, I'm like, oh yeah, that's what they do there. You know, like the use of medicine, sort of the use of quality assurance and quality management, the managed care. Managed care is definitely a medical kind of construct, and those are the things that seem to be coming and impacting the addiction field. And you have a check? I'm going to check it real quick just to make sure I'm doing okay on time. And so that's sort of what's impacting, in my opinion, the addiction field pretty heavily. And what I'm going to talk about next here, actually, you know what I'm going to do? I'm going to make a bit of I'm going to talk about this a little bit, but I'm going to save some of these next slides for the health reform panel, just because I think there's some good things in here we could use there, and since we need another speaker for that panel. This is an index we developed at NIATx 3 years ago. When health reform first became an issue, we formed a collaborative of 23 organizations around the country, and we did it through a solicitation where we said, if you are interested in planning for health reform, join this group. And we had about 40 organizations who applied, and we accepted 23 of them. And then within that group, we said, okay, hey, these are the things we think you should be focusing on for health reform. And then they sort of looked at the list and said, throw that one out, we'll take those 2, throw that one out, we'll take those, those 3. And so we sort of worked back and forth, and we came up with this list here. And this list when I looked at this list for the first time, just as a whole, I said, this is medicalization of addiction treatment. This is a lot of what general providers do. I mean, Tony, working at Johns Hopkins, you probably see a lot of this stuff just because it's part of hospitals and clinics. But just a lot of the things you see here, like around licensing of workforce, patient records, electronic records, outcomes measurement, quality management. I mean, it's all the stuff there. But one of the key, and so more and more, I think we're finding that for people to participate in managed care plans, you're going to have to be connected with a primary care provider, either through collaboration or closer. And that's sort of looking ahead. I know that's not here and now. And so we really, more and more as we're saying, what do people need to do to prepare for reform? We really came up with a few things, and one of them is around integration. The other one is like electronic health record. You've certainly heard about that. The other's around billing and reimbursement kind of things. And so, and really right now, that's what's sort of pushing the integration movement is the potential of health reform and the whole issue of medical homes. Now, a question I'll ask you: if the Supreme Court, sort of shoots down health reform, or a Republican president comes in and shoots down health reform, do you think the integration movement will stop at that point?
I can tell you, I'm with the Department of Health and Mental Hygiene. I can tell you that our secretary has made a decision that no matter what happens, Maryland is moving forward with this. Mm-hmm. We have legislation already around health exchanges, essential benefit packages. Mm-hmm. So I think in Maryland, they're pretty much, have determined that would be the policy.
Yeah. And that's what I'm seeing too. Actually, is there's a lot of movement. I think integration as sort of is an approach. More and more people are seeing the benefit of it. So I'm just seeing a lot of momentum that way. Right. And so I think if health reform were, tragically to just sort of halt, I think that whole thing would move ahead. Maybe not as quickly, but it would certainly continue. So that's sort of the reasons why I think you're really doing what you're doing now is very important. And just keep planning for some of these things that you really can anticipate. I mean, it's just going to be part of the future. And then with some of these other things, when we're talking about some of the health reform topics, I'll talk about that a little bit more this afternoon. Before Aileen sort of takes over and gives some examples around integration and the like, any questions or just observations? Let me ask this question. Right now, like about a year ago, I talked about integration. About 10 or 20% of the people in the audience would sort of glue onto it. Now I talk about it maybe 60 to 70%, but you still have a pretty large group that just sort of is acting like it's not important or it's not going to happen or something. Why is that, do you think? I mean, just.
I would say, at least my initial impression of doing that is that it's a huge task.
Yeah.
that it's a lot of work. And
So you have all these
already-
other things doing and going on.
Yeah, already
Yep.
with the, you know, level of work for all of our staff and administration, it almost seems like unmanageable, which actually was one of the things that we realized it was not as much work as it seemed to be initially, for the little bit that we did, but I think that was at least my first gut that I was like, oh, we don't have time for that, you know?
So the classic, there's these different fires burning, so to speak, and it's like, okay, I need to really focus on these three right now. So this,
Yeah.
you know, for some organizations, this may not be one of the immediate fires, so to speak. Okay. Go ahead.
One of the things that I see, I think, is a real problem, I know it's so hard for the providers, is that there are a lot of barriers, system barriers.
Right.
So no matter how hard somebody wants to do, you know, to the kind of efforts they want to put into this, I mean, right now, if you have somebody with a co-occurring disorder, you know, our system isn't set up right now for you to put a primary diagnosis of both mental health and addiction. You know, there are just, we don't have a data system that...
Oh, you know, like the VA example I gave earlier.
Oh, the VA is wonderful, yeah.
Yeah, but I mean, it's a good
Ours
it's a
is
good
very
goal,
fragmented
but-
right
oh,
now.
yeah.
Not saying that we're not working on it. And I think this is, yeah, I don't know if you're familiar with Ken Minkoff, Dr. Minkoff. He always says, and which I love, is that, you know, you have three levels of integration. You have the system level, you have the program or practice level, and you have the clinician level. And I think at this point in time with healthcare reform, all these levels are working on things, maybe not the same thing, but simultaneously, so that we're all moving ahead in the right direction. I know right now, you know, at the system level, we're talking about a new financial reimbursement system. You know, we're trying to design something now that will encompass all of this stuff. And then make it easier for people to be treating the population. And we know we have a high prevalence of co-occurring disorders. So I think it's really difficult right now for people with electronic medical records. You know, there's so many out there, and they're costly.
Yep.
And how do you figure out which one you can afford that's going to fit into the needs, you know, that will be. So, I mean, I could go on and on and on, but I really think
You know,
that...
here in Maryland, can you bill for a clinic visit and a mental health consult on the same day?
Well, interestingly enough, the federally qualified community health centers can. That's my understanding. But even there was a difference of opinion even within that group. Some weren't feeling that they could bill twice in one day. And it goes around to even groups, you know, depending on...
So there's different...
There's a whole lot, yeah.
Did you know what Medicaid says about it?
Yeah. I don't know if that's been resolved or not, but I know I've heard lots of... yeah, it is huge. It really is. And
for the integration piece.
So, yeah. So I personally say to people, you know, like I do every day, I get up and I say, okay, what do I have control over and what don't I?
I've heard that saying before.
And then
Lord,
just
give me the
work on those things, you know?
Yep. Yeah, well, I'm glad you're here, and thanks for identifying. I mean, that's part of all this is identifying system barriers and trying, you know, addressing them.
I am the state administrator for co-occurring disorders, so
There you
that's
go.
why, you know, and I'm so thankful to be here today.
That's good
I
to
think
have
this
you.
is wonderful that you're all doing this at Danya, and you know, I've been to NIATx training, but I work all over the state. I work with all of them, so I can tell you that, you know, these are very challenging times.
Yep, for sure.